So this is the CTR coding break abstracting stomach primaries. I'm hoping my computer complies. Let's see. So today's objectives, we're going to talk about anatomy and physiology of the stomach. We're going to review risks, signs, and symptoms of stomach cancer. And we'll go over the clinical workup for diagnosis of stomach cancers. We'll review assigning primary sites. We'll go over histology coding, SSDI coding, AJCC, and SEER staging. I'll review some coding tips, and we'll review a case example. The stomach is a muscular organ located on the left side of the upper abdomen. It is a hollow and J-shaped organ. The stomach is the largest, most dilated part of the digestive system, and it lies between the cardiac and pylori orifices. There are four main regions of the stomach: the cardia, or the cardiac region. It is the point where the esophagus connects to the stomach and through which food passes into the stomach. This is the blue area of the image on the current slide. Located inferior to the diaphragm and above and to the left of the cardia is the dome-shaped fundus. Below the fundus is the body, or the main part of the stomach. The funnel-shaped pylorus connects the stomach to the duodenum. The wider end of the funnel, the pyloric antrum, connects to the body of the stomach. The narrower end is called the pyloric canal, which connects to the duodenum. The smooth muscle pyloric sphincter is located at this latter point of connection and controls stomach emptying into the small intestine. The medial and lateral borders of the stomach are curved, forming the lesser and greater curvatures. The greater curvature forms the long, convex lateral border of the stomach, and the lesser curvature forms the shorter, concave medial surface of the stomach. The stomach is much like a sack with a lining. The stomach wall is made of several layers. The mucosa is the first and innermost layer or lining, and it contains the glands that release digestive juices. These are called hydrochloric acid and pepsin. This is where most stomach cancers start. Submucosa is the second layer which supports the mucosa. It is rich in blood vessels, lymphatic vessels, and nerves. The muscularis is the third layer and is made of thick muscle. They help to mix food with the digestive juices. Subserosa is a layer which contains supporting tissues for the serosa, and the serosa is the last and outermost layer of the stomach. It's the lining that wraps around the stomach to confine it. The stomach's function is to store and macerate food and begin the early stages of food digestion. The stomach creates digestive juices and breaks down food. So after you chew and swallow food, it enters your stomach from the esophagus. At this point, pepsin and hydrochloric acid are released from the stomach, and your stomach muscles create a rippling motion which combine the food with digestive juices. After about 2 to 3 hours, partially digested food moves into the small intestine. This is where it's broken down further and over time absorbed by your body. The acid also works to kill harmful microbes that may have made their way into your body along with food and drink. The acid could damage the stomach, so it secretes a sticky, neutralizing mucus that coats its walls and protects it from damage. The stomach can hold a bit more than a quart or 1 liter of food at once. The design of the stomach allows a person to eat a large meal that can be digested slowly over time. It can take 4 to 6 hours or longer to digest a meal. The higher the fat content of the food, the longer it takes for the food to digest. The gastric rugae are the redundant folds of gastric mucosa that are most prominent when the stomach is collapsed. Gastric mucosa is composed of columnar epithelium, and it typically runs longitudinally and creates these creases or folds in the gastric mucosa that increase the stomach surface and allow for an increase in volume without an increase in pressure. This is why competitive eaters can eat so much. The stomach stretches to accommodate the amount of food that is ingested with the rugae. There are factors that may raise a person's risk for developing stomach cancer. Age being the first one on the list, stomach cancer occurs most commonly in people older than 55, and typically people diagnosed with stomach cancer are in their 60s and 70s. Men are twice as likely to develop stomach cancer as women, and H. pylori, a bacteria, is a common bacteria that is known to cause inflammation and ulcers of the stomach. It is also considered one of the main causes of stomach cancer. Family history, whereas individuals with family members with stomach cancer have a higher risk of developing stomach cancer. Race or ethnicity, where the stomach cancer is more common in Black, Hispanic, and Asian populations. Those who eat a diet high in salt have been linked to an increased risk of stomach cancer, and this includes salt added by salt preserving or pickling. A history of previous stomach surgeries, such as bariatric surgery, those could also increase your risk for stomach cancer. Occupational exposures to certain dust or fumes have been known to increase the risk for stomach cancer, as well as tobacco or excessive alcohol use. And finally, obesity. Research has shown that excessive body weight increases a man's risk of developing stomach cancer, but it isn't clear whether obesity increases women's risk for stomach cancer. People with stomach cancers may experience several common symptoms. Sometimes people with stomach cancers do not have any symptoms though, and they're found incidentally on tests for other reasons. Stomach cancer is usually not found at an early stage because oftentimes there are no symptoms. Currently, there's no recommended screening for stomach cancer for people before symptoms or signs appear. In general, it is more common for people to be diagnosed with stomach cancer after symptoms and signs do appear. Interesting, though, Japan has a higher incidence of gastric cancer being detected in an early stage due to a rigorous screening process, but unfortunately, the US does not practice this. When symptoms do occur, they may be vague and can include those listed on the slide. It's important to remember that these symptoms can also be caused by many other illnesses, such as stomach viruses or an ulcer. Patients presenting with symptoms and those with multiple risk factors for gastric carcinoma require further workup. The esophagogastroduodenoscopy, or the EGD, is the diagnostic imaging procedure of choice in the workup for gastric carcinoma. An EGD is highly sensitive and specific diagnostic test, and especially when it's combined with an endoscopic biopsy. Multiple biopsy specimens should be obtained from visually suspicious areas, and this step involves repeat sampling in the same tissue site so that each subsequent biopsy reaches deeper tissue into the gastric wall. A double contrast barium swallow is a cost-conscious, non-invasive, and readily available study. It may also be the initial step for diagnosis. This radiographic study provides preliminary information that may help the physician determine if a gastric lesion is present and whether the lesion is benign or malignant. Stomach cancer can often appear as gastric ulcers, and if ulcers are present, further testing may be needed. Biopsy is often done and performed on the ulcerative tissue. After the initial diagnosis of gastric cancer, a further evaluation for metastases is necessary to determine treatment options. A computed tomography or a CT scan is a useful method of detecting liver mets greater than 5 millimeters in diameter, perigastric involvement, peritoneal seeding, and involvement of other peritoneal structures such as ovaries or the rectal shelf. However, CT scanning is unable to allow assessment of tumor spread to adjacent lymph nodes unless they are enlarged. In addition, it has not been shown to be effective in allowing determination of the depth of tumor invasion and cannot reliably support detection of solitary liver or lung metastases that are smaller than 5 millimeters in diameter. The endoscopic ultrasonography, or an EUS, is a modality that allows for more accurate staging. In EUS, the transducer is placed directly next to the gastric wall, and high-frequency sound waves are used to determine the depth of tumor invasion and detect local lymph node involvement, which may be assessed by operative biopsy. Sometimes staging is provided by the performing physician, and we'll discuss this type of staging a little bit later in the presentation. FYI, because tumor depth and lymph node involvement influence survival, EUS is an important tool for increased preoperative staging. However, EUS cannot permit assessment of tissues beyond the depth of 5 centimeters and therefore cannot be used to assess distant lymph node involvement or to screen for lung or liver mets. Recent literature supports the combination of CT scanning and EUS for preoperative staging of gastric cancer to best determine the number and location of involved lymph nodes. As we reviewed in the earlier slides, the primary sites for the stomach include the cardia, or the esophagastric junction, the fundus of the stomach, the body of the stomach, the gastric antrum or the pyloric antrum, the pylorus, the lesser curvature of the stomach, which is a not otherwise specified code and is non-classifiable to the 16.0 to 16.4 codes, and then the greater curvature of the stomach, which would not be classifiable to C16.0 to C16.4, an overlapping site, C16.8, and then just stomach NOS where we don't have any other information, then it's just in the stomach. Schema discriminator is used only when the primary site code is C16.0 or that cardia. Any other primary site than C16.0, the schema would not apply. To determine whether a cancer of the cardia should be staged in the esophagus chapter or the stomach chapter, it's necessary to identify the midpoint or the epicenter of the tumor. The true anatomic EGJ corresponds to the most proximal aspect of the gastric folds. Chapter 16, esophagus and EGJ, is a tumor involving the EGJ with the epicenter of less than 2 centimeters into the proximal stomach, while Chapter 17 for the stomach of the AJCC is no involvement of the EGJ or unknown if EGJ is involved, and the epicenter at any distance of involvement in the stomach. The epicenter can be calculated by looking at the midpoint of the tumor. If the tumor is at a stretch from 40 to 45 centimeters, let's say it's in the esophagus, so we're at that cardia, the epicenter is at 42.5 centimeters. And to calculate this, we take that 5 centimeter stretch, we divide it in half, and that gets us 2.5 centimeters. Then we take the most proximal measurement from the esophagus, which is 40 centimeters, and we add the 2.5 centimeters to that, and we get 42.5. So 42.5 is at 2.5 centimeters below the EGJ, which is typically at 40 centimeters. The CAP protocol uses the term midpoint instead of epicenter, so you might see that used interchangeably. This is the pathologist's assessment of the point of tumor origin and regardless of the tumor extension into other tissues. So if we take a look at this particular schema discriminator a little closer, we have specific codes here on the slide. So you'll see code 0, no involvement of esophagus or EGJ. That's where the cardia is involved only. So that would be staged in Chapter 17. Code 2 is involvement of the esophagus or EGJ, and the epicenter of the tumor is less than 2 centimeters into the proximal stomach, which is by saying the same thing as within 2 centimeters of the EGJ, or the EGJ is involved, but there's no mention of extension into the stomach. That is staged in the esophageal cancer chapter 16. Code 3 is involvement of the esophagus or EGJ, and the epicenter is greater than 2 centimeters into the proximal stomach. So that just means that it's 2 centimeters below the EGJ and staged in chapter 17. Code 9 is used when it's unknown if there's involvement of the esophagus or EGJ, and the epicenter is any distance into the proximal stomach, and that is coded in chapter 17. So there's some examples on the current slide as well, where we have a mass from 42 to 44 centimeters, and it's clearly stated that the EGJ is not involved. So we calculate the epicenter, and that turns out to be 43 centimeters, but because the EGJ is not involved and the primary site is at the cardia, we're still going to stage it just in chapter 17 stomach. Mass at 40 to 42 centimeters involving the EGJ, and that's we have the calculation on there as well. So the epicenter would be 41 centimeters. And if we look at where the EGJ is, that's at 40 centimeters. So that's less than 2 centimeters from the EGJ. So we're going to stage it in chapter 16. And finally, the mass at 45 centimeters involving the EGJ at 40 centimeters. We have a epicenter of 42.5 centimeters. And we're going to code that to 3 because we have greater than 2 centimeters from the EGJ and stage in chapter 17. So we can try assigning a primary site. So the case example we have is an 85-year-old female with complaints of nausea, vomiting after eating, feeling of fullness. We have endoscopy where at the scope we show a 2.3 centimeter ulcerative lesion identified in the stomach, and the lesion begins at the fundus and extends to the cardia. Partial gastrectomy is performed, and a 3.5 centimeter tumor adjacent to the cardia at the fundus, and the tumor is ulcerative and extends toward the cardia. So how would we code the primary site? We have AC16.9 for the stomach NOS, B16.1 for the fundus, C16.0 for the cardia, and D16.8 for overlapping. And I'm just going to give you a minute to look at this case scenario and see what you come up with. Well, maybe not a minute. If you said C16.1, then you are correct. That's the fundus. The lesion is stated to begin at the fundus of the stomach per the description on the scope and the partial gastrectomy. Even though we know the tumor is overlapping for the 2 sites, we do have an area of origin that's clearly stated, but they're not always this easy. So maybe let's try a more difficult case. So this one we have on EGD, a gastric ulcer at the lesser curve with large amounts of woody changes of the surrounding gastric antrum, and they also state that's at the pyloric antrum. 7.9, we have a CT of the abdomen with gastritis and considerable edema in the wall of the stomach with large perforated posterior ulcer in the gastric antrum. And on 7.15, a diagnostic laparoscopy, there's a distal gastric cancer and tumors visualized on the EGD. So what would you code the primary site to here? A, C16.5, lesser curvature. B, C16.3, gastric antrum. C, 16.2, body of stomach. Or D, 16.9, stomach NOS. And I'll just give you a little time to make your guess. And this is not a poll, it's just, you can just do this on your own. All right, so if you said 16.3 gastric antrum, then you're correct. The lesser curvature provides the general region medial to the stomach where the tumor is located, but the pyloric antrum is the exact region along the stomach wall where the tumor is located. So if the tumor site can be more specific than C16.5 or C16.6, we're going to use the more specific tumor site. So if we move on to histology codes, adenocarcinoma stomach cancer starts in cells that produce mucus. This is the most common type of stomach cancer, with nearly 95% of all stomach cancer cases that are adenocarcinomas. There are many subtypes of adenocarcinoma that are listed in the ICD-10 and ICD-10 3.2. Signet ring cell carcinoma is also another type of stomach cancer that is seen, but not as often as adenocarcinomas. Leonidas plastica refers to a complete involvement of the stomach with a leathery type appearance. Lymphoma can also originate in the stomach if the body sends immune system cells to the stomach. This might happen if the body is trying to fight off an infection. Most lymphomas that start in the stomach are non-Hodgkin lymphomas. Leiomyosarcoma of the stomach presents in approximately 1% of cancer cases, and sarcoma arises in the viscera of the stomach. A gastrointestinal stromal tumor, or a GIST, starts in the special nerve cells that are found in the wall of the stomach and other digestive organs, while carcinoid tumors are cancers that start in neuroendocrine cells. Carcinoid tumors are a type of neuroendocrine tumor, and you may also see large or small cell neuroendocrine carcinomas. It's important to remember for the stomach, intraepithelial neoplasia or dysplasia, high-grade dysplasia in the adenomatous polyp, and the high-grade intestinal type adenoma sound not reportable, but they are incorporated in AJCC 8th edition and with TIS staging classifications, and they are reportable. So be sure to review your most recent ICD-10 3.2 for reportable neoplasms. Typically, high-grade dysplasia alone would not be considered cancer, but for the stomach, it can be reported as in situ with the appropriate description beginning 2022 and forward. There's only one SSDI collected for stomach cancer cases diagnosed January 1st, 2021 and forward, and from 2018 to 2020, there are no required SSDIs for the stomach. This new SSDI is collected because HER2 testing is part of the NCCN guidelines under the gastric cancers and done if the patients are suspected or documented with having metastases. HER2 monoclonal antibodies may be added to chemotherapy for patients with HER2-positive disease, and often Herceptin is given, which increases their chance of living longer in comparison to chemo alone. It is noted within this document that HER2 as well as PD-L1 testing are both done if metastatic adenocarcinoma is documented or suspected. And again, this is only reported for 2021 diagnosis years and forward, and you'll leave this field blank if pre-2021 diagnosis year. Notes 1 through 3, I pretty much went over. Note 4 talks about the result of the HER2 test performed on primary tissue is to be recorded in this data item. We use the highest or the positive versus any negatives when there are multiple results. Also, if neoadjuvant therapy is given, we would record the assay from the tumor specimen prior to neoadjuvant therapy. But if neoadjuvant therapy is given and there's no HER2 results pre-treatment, then we may report the findings from the post-treatment. All right, so if we move on to AJCC 8th edition staging, the 8th edition classifies stomach by 3 prognostic staging categories: clinical, pathologic, and post-neoadjuvant. There are no tumor markers or factors that affect staging classifications other than the T, N, and M categories. A major change from the AJCC 7th to the 8th edition is the removal of the separate staging for SCC versus adenocarcinomas of the stomach. Now all staging applies to all histologies unless excluded from staging, such as Leonidas plastica, or any NOS histology such as carcinoma NOS. As noted by the AJCC, staging from the primary gastric adenocarcinoma depends on the depth of penetration of the primary tumor. CTX is when you have no information on the primary tumor available, and CT0 is when there's no primary tumor identified. CTIS, or in situ only, and it has no invasion into the lamina propria. T1 designation is subdivided into T1A for invasion of the lamina propria or muscularis mucosa, and T1B invasion of the submucosa. T2 is invasion of the muscularis propria, but further explanation is given. A tumor may penetrate the muscularis propria with extension into the gastrocolic or gastrohepatic ligaments, or into the greater or lesser omentum without perforation of the visceral peritoneum covering these structures. In this case, the tumor is classified as a T3. If there is perforation of the visceral peritoneum covering the gastric ligaments or the omentum, then the tumor is classified as a T4. T3 is invasion of the subserosal connective tissue without invasion of adjacent structures or the serosa or the visceral peritoneum. There is a further explanation available for this. It's that the adjacent structures of the stomach include the spleen, transverse colon, liver, diaphragm, pancreas, abdominal wall, adrenal gland, kidney, small intestine, and retroperitoneum. Intramural, or that extension within the walls of the stomach, to the duodenum or the esophagus is not considered invasion of an adjacent structure, but it is classified using the depth of the greatest invasion of any of these sites. T4 tumors invade the serosa or the adjacent structures, and further subdivision is based on penetration of the serosa alone, T4A, or invasion of the adjacent structures or organs, T4B. EUS correlates highly with the CT categories. These levels of invasion can typically be seen on endoscopic ultrasound, and we request that you record your findings from these procedures in your scopes text so that we can have the best information available. Clinical evaluation of nodes includes imaging and an FNA, or a biopsy of lymph nodes in the regional nodal area. The more nodes involved clinically, the higher the nodal category. CNX, we can say we cannot provide any information on nodes. Maybe there was nothing done to evaluate nodes. While CN0, there were tests done, but no nodes were clinically indicated. The specific regional nodal areas are as follows. Perigastric along the greater curvature, and this includes greater curvature, greater omental nodes. Perigastric along the lesser curvature, including lesser curvature and lesser omental. Right and left pericardial or cardioesophageal. Suprapyloric, including the gastroduodenal nodes. Infrapyloric, including gastroepiploic. Left gastric artery, celiac artery, common hepatic artery, hepatoduodenal, or along the proper hepatic artery, including the portal, and splenic artery and splenic hilum. So N1 would be broken down as METs to 1 to 2 regional lymph nodes. N2 is METs to 3 to 6 regional lymph nodes. N3 is METs to more than 7 plus regional lymph nodes. Now N3 can be subdivided by the number of lymph nodes if greater or equal to 7. So N3A is METs to 7 to 15 regional lymph nodes, while N3B is METs to 16 or more. Per AJCC, the most common metastatic distribution is to the liver, peritoneal surfaces, and non-regional distant lymph nodes. Central nervous system and pulmonary METs occur, but are less frequent. Tumors found in these locations are considered metastatic, or M1. In contrast, direct extension of bulky tumors to the liver, transverse colon, pancreas, and/or undersurfaces of the diaphragm are considered tumor invading adjacent structures and coded to T4B, not M1. Positive peritoneal cytology is classified as metastatic disease and coded to M1. So this is a clinical prognostic staging table from the AJCC 8th edition. You can see the combinations of the nodal involvement and the level of invasion. The table changes from clinical to pathologic, and there are far more combinations of T and N values for staging categories. For this presentation, pay attention to the CT1, CN1, and CM0. Which is the stage group for the next couple slides. I'm just going to show T1, N1, M0. So we have on the clinical stage group here, we have a 2A. So this is just a small sampling of the pathologic prognostic stage table from the AJCC 8th edition. You can see the combinations of nodal involvements and levels of invasion are far more extensive than the clinical. So where T1, N1, and M0 was 2A clinically, it is a stage 1B pathologically. So be sure to keep your staging separate and use the appropriate staging tables. Per the AJCC 8th edition, surgical resections that qualify for pathologic staging include total, near total, subtotal, partial, proximal, and distal gastrectomies and an antrectomy. Primary tumor or the depth of tumor invasion should be based on the microscopic examination by a pathologist. And these are surgical codes A300 to A630 for the 2023 surgical codes and can be found in the STORE manual. This is just a small sampling of the post-therapy prognostic staging table from AJCC. You can see the combination of the nodal involvements and again, the levels of invasion, and they're slightly different from the clinical and pathologic staging. So now if we look at T1, N1, and M0, we have a stage 1. So treatment that qualifies for neoadjuvant or systemic therapy includes chemo, hormone, immunotherapy, or radiation administered to shrink or alter the tumor prior to resection. And this is typically done for tumors that are very large or have involvement of adjacent structures or organs. SEER Summary Stage is organized by kind of the same chapters. The stomach chapter falls in the digestive and hepatobiliary systems. This is a section of the summary staging manual that contains the stomach and the esophagus. It includes the histologies listed for the stomach and the EGJ. So be sure that the histology does fall in these ranges. For example, a gist of the stomach is staged in the soft tissue gist chapter and not in the stomach chapter. Something to take note of, per the SEER Summary Manual, there is note 3, and again, it explains kind of the same explanation as the schema discriminator 1, where if the tumor involves the EGJ and the epicenter is less than or equal to 2 centimeters, we're going to use the esophageal cancer chapter for this staging. Tumors involving the EGJ with greater than 2 centimeters from the EGJ are in the stomach chapter, and cardiac cancers that do not invade the EGJ should be classified based on the stomach cancer chapters for the summary stage. So there's in situ, non-invasive, intraepithelial, and these are coded to 0. And they're included in the coding for adenocarcinomas and a polyp that is also stated to be non-invasive. Localized disease, or code 1, is confined to the stomach per the SEER manual, and that also includes extension through the wall, implants within the stomach, invasion into the muscularis propria or submucosa. This also includes Lionitis plastica and any invasion of the subserosal tissue. Direct extension is labeled code 2, and that involves adjacent or connective tissue invasion, involvement of the colon or the mesocolon, the duodenum, via the serosa, the ligaments such as the gastrocolic, gastrohepatic, or gastrosplenic, the liver, and invasion of perigastric fat or the serosa. Regional nodes are described in this section. Regional to the stomach includes celiac artery, common hepatic artery, perigastric, pyloric, splenic. So there's an entire list of regional lymph nodes within the manual. This is not all-inclusive here. You will definitely need to look at the manual to get the full list of regional lymph nodes. And the Stage 4 is when you have involvement of both 2 direct extension and 3 regional lymph node involvement. You would have to have both present in order to code 4. And finally, stage 7, we have distant sites, including further contiguous extension to the abdominal wall, kidney, retroperitoneum. There's also involvement with distant lymph nodes, and those include mesenteric, para-aortic, and also carcinomatosis, or if we have a Krukenberg tumor or malignant peritoneal cytology. Also can be coded to 9, but we do not like using 9 as long as you have information about staging, such as any kind of imaging or evaluation of the patient. Usually you can assign some kind of stage. So we have some coding tips. A common error is with tumor size, coding that tumor size, those tumor size fields. There's 3 of them. So clinical tumor size is important to remember to review your clinical imaging, including any scopes for any size of the tumor identified. If it's stated to be diffuse, widespread, 3/4 or more, or Leonidas plastica, you can code it to 998. And where if there is no size indicated, then you can code 999. Use the largest size for the pathologic tumor size, and just make sure that you are coding the size from the resection as long as no neoadjuvant treatment has been administered. And tumor summary size. If the size on resection and there's no neoadjuvant treatment, you're going to code the tumor summary size to the pathologic tumor size, even if it's smaller than the size that was identified clinically. Clinical assessment of depth of invasion and nodal involvement, as well as some limited area of distant disease, may be facilitated by the use of EUS or endoscopic ultrasound. The U classification can be found in the medical record and is typically assigned by the performing sonographer and marked with a U prefix. Unless the managing physician has reviewed the EUS results along with all the other clinical information, do not use the U classification as a form of clinical staging. In the words of Donna Grass from the AJCC, there are no U staging classifications. The managing physician is the one responsible for synthesizing all this information, the physical exam, each of the imaging studies, the scopes, and any other diagnostic workups. All of this information is put together to assign the appropriate clinical stage, CTNNM, and clinical stage group for the patient can then be assigned. So there are some tips for assigning grade for the stomach. As I noted in an earlier slide, specific surgery requirements for assigning pathologist staging, they do not apply here for grading. In many chapters within the grade manual, we see under the pathologic staging section, clinical case only, which directs us to review the clinical grade section for the stomach. In any sort of treatment or surgery type if any sort of treatment or surgery type was excluded from the pathologic grading, it would be listed in the grade manual. There's no exclusion listed in the grade manual for stomach though, so we can assume that any surgery performed is enough to assign path grading. An example of this would be clinical stage where TURP or a TURBT is performed for bladder or prostate cancer, and we're instructed to assign the clinical grade only for these procedures. Use the clinical grade for the pathologic grade when surgical resection to the primary site is done, but a grade is not provided on resection. Surgical resection is done, but there's no residual tumor, but there was also no neoadjuvant treatment. And surgical resection not done, but they do have evidence of microscopic distant mets. Surgery coding tip that may be helpful: coding local tumor excisions. Endoscopic mucosal resection, or an EMR, is becoming more and more popular, and endoscopic submucosal dissection, ESDs, are also being seen. These are procedures that can be used to treat some very early stage cancers, and when the tumor is not thought to have grown deeply into the stomach wall, then the chance of spread outside the stomach is very low. These procedures do not require an incision in the skin. Instead, the surgeon passes an endoscope down through the throat and into the stomach. Surgical tools can be passed through the endoscope to remove the tumor and some layers of normal stomach wall below and around it. The ESD actually goes deeper into the stomach wall than the EMR. These operations are not done as often in the US as they are in some Asian or East Asian countries like Japan, where stomach cancer is more commonly identified during an early stage due to the screenings. This type of procedure would be coded as a local tumor excision, or code A200, as no removal of the stomach is taking place. Combination of A200 with PDT, electrocautery, cryosurgery, laser ablation, and laser excision use codes A210 to A250. So we can get into our case study, and we did put the handout out on that site, so you were able to take a look at this case before we started. I'll just briefly go over the case study. There was an EGD where a 3-centimeter mass is obstructing. We have a mass in the antrum with gastric outlet obstruction suggestive of the gastric malignancy. The margins are well defined and partially involving the incisura. Mass appears to involve the perigastric fat, and a biopsy is obtained at that time. There is a CT on 115 where they note a regular distal gastric body and gastric antrum with mesenteric haziness and hypotenuation of areas in the distal gastric body and antrum to the pylorus suspicious for primary gastric neoplasm. 1 to 2 nodes are measuring up to 1.5 centimeters that are suspicious for METs. And then a PET confirms that there is 1 centimeter mass in the gastric antrum with proximal gastric dilation and partially obstructing distal gastric carcinoma. Mild soft tissue infiltration around the mesenteric fat, but no discrete enlarged or FDG avid mesenteric lymph nodes. The patient undergoes chemo on 2/27/23. And adjuvant chemo on 5/13/23. So on 1/7, the endoscopic biopsy of the gastric antrum mass, well-differentiated adenocarcinoma intestinal type, is identified. So that patient undergoes chemo, and then on review after the treatment, the imaging did state, it was 4/25, I believe, that stated that there was response to treatment. On 3/31, it wouldn't be 4/25, I apologize. Let me go back real quick. It is 4/25/23, complete response to treatment. Yes, I was correct. So on 3/31, the patient undergoes a distal gastrectomy, and there's no residual tumor and regional lymph node dissection, 10 out of 13 positive lymph nodes. And the pathologist states PT0N3A. On 1/30, the surgical oncologist states this is intestinal type gastric adenocarcinoma and possible involvement of the mesenteric vein, and we recommend neoadjuvant chemo to shrink the tumor. The patient was then referred to a MEDOC. 2-1, the med-onc states this is a probable T3N1 stage 3 gastric cancer with involvement of the perigastric fat and perigastric regional lymph nodes. On 3-1, the med-onc states that there's continued current chemo regimen as there's a clear response to treatment. And on 4-10, the med-onc states after we're healed from the surgery, we're going to continue adjuvant chemo as a form of maintenance. So there's a lot going on in this case study, and you pretty much have to jump around to the different dates, but that's really no different than regular abstracting. So let's take a look at the case results. The data diagnosis would be coded to 1-7-23 as there's a positive biopsy and there's no clinical diagnosis prior to this. Histology would be coded to 81-44 with behavior 3 as the biopsy results state adenocarcinoma intestinal type, and this is the only histology identified during the patient's course of treatment and diagnosis. Primary site C16-3, gastric antrum, and that's based on the pretreatment EGD and imaging available, and the primary is not stated by the managing physician, so we are relying on the information that we do have. Grade C, P, and YP, which is clinical, pathologic, and post-therapy. Grade 1 for clinical, as we have a well-differentiated adenocarcinoma on biopsy. The path grade would be automatically a 9 because we have neoadjuvant treatment. And since there's no residual on resection, but neoadjuvant treatment is administered, our post-therapy grade must be coded to 9. Our surgery code would be A320, and this is the only information that we have. It's distal gastrectomy, and that is coded A320 because the term distal is included in the description. Now, A310 must be less than 40% of the stomach per the code description, so we're not going to use that code. AJCC clinical TN and M, we have a T3N1 M0 stage 3. The med-onc does state this is a stage 3 T3N1 before any treatment based on imaging, and clinically there's no evidence of distant mets. AJCC path staging is left blank because neoadjuvant treatment. AJCC post-therapy staging is YPT0, YPN3A, CM0, and we assign a stage 88. The pathologist does state this is a T0N3A with neoadjuvant treatment on resection, and we assign stage 8 because we don't have the ability to assign a stage per AJCC for T0 tumors. SEER summary stage would be coded to 4. Clinically and pathologically, this was regional by direct extension, so code 2, and regional lymph node involvement, so code 3, by the physician stating perigastric fat with perigastric regional lymph node involvement. The tumor was never localized or metastatic, and we have to use all the information available, including neoadjuvant. Code 4 is when you have a combination of 2 and 3. A bonus question here, we have tumor size clinical, pathologic, and then summary size. So clinically, we have it mentioned that it's a 3 centimeter mass on EGD, so we would code 030. Tumor size pathologic, we would leave as 999 because we have neoadjuvant treatment. We're not going to know the true pathologic size. And we would put 030 in our tumor summary size. And that's our clinical size, so that's what we're going to use for our tumor summary. So in conclusion, we reviewed the anatomy and physiology of the stomach and discussed the risk, signs, and symptoms of stomach cancer, and reviewed the clinical workup for stomach cancers and discussed assignment of primary site, histology, and SSDIs, and went over our staging. Finally, we reviewed our case example and coding and rationale. So I hope this was very informative for you, and we can open up for the rest of the time we have available for a chat about any questions that you might have. I'm just gonna fast forward through here and leave it on the information page. Oh, this is my contact information. It should be in the slides. Sure, thanks, Carrie. I'm just gonna leave it on this slide here. I think we have about 10 minutes available if there's any questions.